Hi everyone, this is Dr. Ahmed D. Abdulwahab. I'm a diagnostic radiologist, and this is the third episode of Highlights in Radiology. First of all, I want to thank you all for all of your amazing great interaction, your subscriptions, your watch time in the last few episodes. You were amazing in supporting me, and I will keep presenting these highlights in radiology in the coming weeks so that we can be better and we can learn more. These topics are short and we will try to limit it to something between 10 to 20 minutes each, and they will be very important in reviewing for the exams because of the lots of images and lots of differential diagnoses for each case. So I would really recommend that you review it and share it with your friends so that everyone can learn. So for today I've chosen an important topic that we see a lot of these cases in everyday practice in CT and MRI and in X-ray, and this is the vertebral neoplasms and the vertebral lookalikes. Lookalikes, what we mean is that they are not neoplasms, not benign, not malignant, but they look like lesions. So we will start as soon as we will not waste any more time, and we will start our topic today with the vertebral neoplasms and vertebral lookalikes. Again, I'm Dr. Ahmed D. Abdulwahab, and this is Highlighting Radiology. So, first of all, let's classify the vertebral lesions into three components or three types. They are the benign, the malignant, and the lookalikes. And for everyone, we will divide it into common and uncommon. And again, the malignant, common and uncommon, and so on. So we will start with the benign vertebral lesions. The benign vertebral lesions, the common ones, the ones that we see a lot in daily practice, are first of all the hemangioma. In this CT scan, we can see that this vertebra is abnormal, and you can see that there are these vertical stripes, what's called corridorary appearance, which is typical of a hemangioma. And again, in the axial images, you can see these dots. This is what's called polka dot sign. So this is typical for vertebral hemangioma, and as I think we all know, the vertebral hemangioma in the MRI is usually hyperintense on T2 and on T1 images, and they lose signal intensity on fat saturated images. So this is typical of vertebral hemangioma, which is quite common and quite painless. The other lesion that we see on the vertebra that is relatively common is the aneurysmal bone cyst, or what's known as ABC. Okay, the aneurysmal bone cyst or ABC, you can see in this lesion, in this image, it's an axial T2 weighted image. You can see that if you look carefully, there are multiple fluid levels contained within the lesion, and this is just blood. It's a bloody lesion, highly vascular. So you can see it's expansile, and it causes expansion of the vertebra. It has multiple fluid levels. This is on the T1 weighted image, not quite characteristic. However, on the post-contrast image, you can see that the areas that contains the fluid levels are not enhancing, only the parts in between, and these are all typical findings of aneurysmal bone cyst. So be careful of that. Now, the last benign lesion that is commonly seen on the vertebrae is an osteoblastoma, which is basically a large osteoma. It's a big one, but without the pain that's relieved by aspirin and all these things. So you can see this is the sclerotic lesion, expansile, but it is not destructive. The cortex is intact. It's not destructive. So this is an osteoblastoma in the vertebra. You can involve the body and the pedicle and the transverse process. All of these things confirms that this is an osteoblastoma, which is a benign lesion of the vertebral body. So the uncommon causes of vertebral body lesions includes, they are not rare, they are uncommon. Okay, we are not saying rare, it's saying uncommon. First of all, the inostosis, or what we know as a bone island or osteoma. Bone island you can see just as a sclerotic tiny dot in the vertebra, and since it's sclerotic, it is hypointense on all sequences, on T1 and T2 and post-contrast and everything. It's hypointense. It does not acquire any signal intensity on the MRI images. It's usually asymptomatic with no clinical significance. You just have to know that this is an osteoid osteoma. The other type is the giant cell tumor. Giant cell tumor. Giant cell tumor usually in skeletally mature patients. It's after the epiphyseal closure, and quite frankly, it's not very common in the spinal column, not common in the vertebra. It's usually in the long bones. However, we might see it. Sometimes you can see here, it's kind of destructive. There is an abnormal area of destruction of the cortex here. And in 10% of the cases, it might even metastasize, although it is not a malignant lesion, but it might metastasize in about 10% of the cases. So keep that in mind. On the MRI also, you can see it here and there, and you can see it's enhancing and it's extending to the adjacent soft tissues, and this is just a giant cell tumor. However, keep in mind, a giant cell tumor can develop within an aneurysmal bone cyst, or the giant cell tumor can develop aneurysmal bone cyst. So it can arise from an aneurysmal bone cyst or can develop within an aneurysmal bone cyst. So they are not that easy to differentiate always. Even if you look here, there is some sort of fluid level or different signal intensities in this giant cell tumor of the vertebra. The other lesion we have to talk about is the osteochondroma. Osteochondroma, it's an exostosis, but not in the long bone. It can be developed also in the vertebra. So you can see here, this is a typical exostosis arising from the vertebra, and it has this cartilaginous cap, and the same thing applies if the cartilaginous cap is more than 5 millimeter thickness. Then we have to be careful about malignant transformation. The same rules of the long bones applies to the vertebra. It's just an exostosis from the vertebra, and it can become large and cause some deformity. The other and the last lesion, also we have here another example of osteochondroma or an exostosis. You can see here, and this is the cartilaginous cap. The other the other lesion that we have is the osteoid osteoma, and the osteoid osteoma, just like you see in the long bones, it's painful and it's relieved by aspirin, and it's usually in teenagers, and you can see there is a lytic area here with a tiny dot here that is the nidus of the osteoid osteoma. Okay, and you can see on the MRI the lesion is right here, and it has edema surrounding it, and it has a tiny dot that is the nidus, and after post-contrast enhancement you can see that it's enhancing here, and this area around it is also enhancing, and again the same features here with the clinical description of pain relieved by aspirin in a teenager. It's typical an osteoid osteoma. So now let's go to the malignant lesions. The malignant lesions that we see in the vertebrae are a lot of different types. However, we will start with the common ones. The common ones include chordoma first. Chordoma is a malignant lesion that arises in two typical locations. This is the sacrococcygeal region. You can see in the CT scan is destructive, it's malignant. Okay, and you can see in the MRI also in the sacrococcygeal region, and the second typical location at the clivus. So you can see also in the clivus. So chordoma usually happens in two typical locations. This is the clivus and the sacrococcygeal spine, and it's one of the common malignant lesions of the spine. Also in the common category we will put Ewing sarcoma, and as I always tell my residents Ewing sarcoma, it's a bone marrow tumor. It arises from the bone marrow. So the bone marrow should be abnormal, and it almost always, keep in mind, almost always has a large soft tissue component. So whenever you see a large soft tissue component with a relatively small primary tumor, keep in mind Ewing sarcoma as the possible diagnosis. Again, you can see here there is a large soft tissue component compared with a small tumor or smaller tumor. Again, you can see in this is T1 and this is T2 weighted image. You can see the large soft tissue component that is enhancing, and on this coronal image you can see it's a huge soft tissue component, again huge, with a relatively smaller tumor. The primary, it's a bone marrow tumor, as what's called round cell tumor, and it's unfortunately very aggressive and usually occurs in children and young teenagers. So this is also another possibility. Keep in mind, lymphoma and leukemia are also possible tumors of the vertebrae. So lymphoma and leukemia, they are also involved the bone marrow. You can see the bone marrow is completely involved, but it's not that much destructive. Instead, if you take an axial image, you see the tumor extending to the surrounding soft tissues. This is also one of the features that we commonly see in bone marrow lymphoma, primary bone marrow lymphoma, or primary bone lymphoma, let's say. One of the commonest lesions that is seen in the vertebra is metastasis. So metastasis, you always put metastasis in the vertebra. Don't forget metastasis in a vertebral lesion. There are typical sites of metastasis, usually involves the pedicle of a vertebra, can be solitary, can be multiple metastasis. You can see here and there. These are metastatic lesions, can be solitary, can be multiple. There may be a known primary or unknown primary. Also, keep in mind multiple myeloma and plasmacytoma. First, let's start with the plasmacytoma. Plasmacytoma, basically, it's a solitary multiple myeloma. If it is multiple, then it's multiple myeloma. If it is single, then it is plasmacytoma. Plasmacytoma has a very typical appearance. This appearance here, which is called mini brain sign. If you look into the lesion, it looks like a brain. Okay, looks like the cerebrum. So this is in the axial images. It's a mini brain sign, which is typical of plasmacytoma, and this is the appearance on the sagittal T2 weighted image. If it is multiple or involves more than one level, then it is a multiple myeloma. Like you can see here, the multiple myeloma are a billion tiny lesions involving all the vertebrae. Okay, and usually it is in like 50s to 70 years old, something like that. So in the more adult population, you can see multiple, the whole bone marrow is abnormal, and this is a feature you can see in plasmacytoma. In multiple myeloma. Again, another example. What do you see here in this CT scan? You see that there is diffuse osteopenia. There is loss of the mineralization of the vertebra. Okay, and this is a feature of multiple myeloma. In the MRI, you don't see a distinct lesion, but these tiny dots here and there. Also in the T1, FATSAT and without FATSAT, this all includes the possibility of multiple myeloma. So, what about the uncommon malignant lesions? And we say uncommon, not rare. So they are not rare, but we don't see them frequently. First, there are a lot of sarcomas like angiosarcoma, chondrosarcoma, fibrosarcoma, I don't know what sarcoma. These are all possibilities of uncommon lesion involve the spine. Very rarely we have anything to distinguish them from each other. For example, you can see here, this is a case of angiosarcoma. It's just a soft tissue lesion that is destroying the vertebra, extending to the soft tissue, and you can see also here, and you can see in the CT scan, it's destroying the bone and impinging on the spinal canal, and here it causes loss of the vertebral height, and again it's impinging on the spinal canal, extending here. This is, and of course, since it's angiosarcoma, it's markedly enhancing. It's angio, it has a lot of blood vessels in it. Okay, so you can put sarcomas in all of its kind. One of the sarcomas that is usually have some characteristic features is chondrosarcoma. Chondro is sarcoma of the cartilage, so it have the features of the cartilage, like this arc and dot calcific foci, and of course there is a large soft tissue component, and it's destructive in nature. You can see the surrounding tissues are destroyed, and you can see in this MRI it's a large, huge lesion, and it has this characteristic appearance of arcs and dots, and this is typically seen in chondral lesions, like in chondrosarcoma in this case. Also, you can see in the axial images, it has a large soft tissue component with multiple hypointense areas involved, which represents the calcific foci. Now, let me clean this slide, please. Now, the giant cell tumor, it can be malignant. We said it's about 10%. It can metastasize. Malignant giant cell tumor typically have nothing to distinguishable or nothing to be known that this is giant cell tumor. Like here you see just a large, huge mass, and it's destroying the vertebra, and it's extending to the spinal canal and to the surrounding soft tissues. Again here and again here, you can see this is giant cell tumor. So you just say there is a malignant lesion that is destroying the vertebra, and differential diagnosis includes blah blah blah. Okay, and also another case of giant cell tumor. First you have to decide whether this is benign or malignant. If you see this destruction and this extension into the vertebral canal, then this confirms that this is a malignant lesion. Again, you can see here, this is the vertebral lesion, and this is the vertebral lesion involving the body and the pedicle, and it has some features of aggressive behavior indicating possible malignant potential. Osteosarcoma is also a possibility in the vertebra, and osteosarcoma in the vertebra can also have the same features you see in the osteosarcoma in the long bones. That is this cloudy appearance, and it's expansile and it's extending to the adjacent soft tissues. So it's just this cloudy appearance. Sometimes it has a soft tissue component, and it's not lytic and not sclerotic. It's something in between. The appearance very characteristic of an osteosarcoma. Keep this appearance in mind. Almost always it's possible to be osteosarcoma. PNET, or the primitive neuroectodermal tumor, it's basically a kind of Ewing sarcoma. So you will have all the features of Ewing sarcoma in the patients with PNET, which includes this large soft tissue component and the tumor arising from the bone marrow. You can see always it has a large soft tissue component, and basically bone marrow tumor with a big soft tissue component. And rhabdomyosarcoma, it's another uncommon malignant lesion that is involving the spine, and again there is nothing really to distinguish it from other tumors. Like you see here, soft tissue mass destroying the sacrum, and you can see here again there is a destruction with soft tissue component extending to the surrounding soft tissues, the spinal canal, and it shows heterogeneous pattern, and you might see some metastatic deposits here and there, maybe in the liver, maybe in the lung. These are the common sites of metastases of rhabdomyosarcoma. Now let's talk about the lookalikes, things that look like lesions, however they are not lesions. This includes first arthritic spondylitis, like rheumatoid arthritis, or gout, or psoriatic spondylitis, or ankylosing spondylitis. There are a lot of spondylitis that they make some kind of lesions. You can see here, for example, these are erosions from the spondylitis, and these are all erosions, and you can see these are erosions all from spondylitis. Another example, these shiny corners, what's called the Romanov sign in cases of ankylosing spondylitis. They might look like lesions, but they are not. Again, these are the shiny corners that we see and consider it part of ankylosing spondylitis. And another example is the eosinophilic granuloma. Eosinophilic granuloma, it's a lookalike, or what's known also as Langerhans histiocytosis. One of the most common features of eosinophilic granuloma is what's called vertebra plana, this appearance. Plain vertebra that is completely squeezed and becomes flat. This is vertebra plana. Keep eosinophilic granuloma in mind, and you can see this appearance on the axial images in the CT scan, and in the MRI you can see all the vertebrae look quite good. There's nothing wrong with them, just one completely totally collapsed vertebra. It is very suggestive of vertebra plan. However, other diagnoses like metastasis, for example, cannot be excluded, so you have to keep that in mind. The other lookalike lesion is fibrous dysplasia, and fibrous dysplasia usually characterized by this cloud-like cotton appearance, and you can see the whole vertebra is involved and it's lost height partially here. And again, you can see the same appearance on this MRI of cases of fibrous dysplasia. Okay, and now you can see this appearance. And the other lookalike lesion, it is not a tumor but looks like a tumor, is the hydatid disease. Keep in mind that hydatid cyst can occur anywhere in the body except the hair, the cornea, and the nail, because these three things, the hair, the cornea, and the nail, have no blood vessels. So otherwise they can happen anywhere in the body. And you can see here the typical hydatid cyst of the vertebra with collapsed vertebra here, and there are multiple innumerable daughter cysts inside. Be careful, don't do any intervention or any biopsy on these because they will rupture and they will spread and might cause anaphylactic shock. Keep it to the surgeon, leave it to the neurosurgeon. Also, Paget disease, it's a lookalike lesion, it's not tumor. Paget disease has three phases, as you all know: the lytic, the sclerotic, and the in between, the mixed one. And you can see this vertebra looks hypointense on T1 and on T2, including indicating sclerotic vertebra. On the CT scan, you can see it's diffusely sclerotic, and this is a feature seen in the sclerotic phase of the Paget disease. So keep that in mind. Paget disease can also involve the vertebrae. And the last thing that we're going to talk about in this episode is spondylodiscitis. Spondylodiscitis in all of its types, whether it's just an osteomyelitis or discitis. For example, it can be caused by tuberous, tuberculous, sarcoid, fungal, brucellar, and other bacterial, all kinds. They might look like this large abscess, the obstructed vertebra, intraspinal extension. You can see in this post-contrast images, spondylodiscitis is a possible lookalike. It is not a tumor, it's an infection, but looks like a tumor with large abscess formation here and there, depending on the types, and you know the different criteria that differentiate the tuberculous especially from the other bacterial kinds of discitis, and I will not discuss it here. That's up to you. You have to study it. So I hope I didn't take a long of your time. It's like around 23 minutes. Again, I'm very thankful for your watch and your subscription, and I encourage you to share it with other people, with your friends, and keep it up. And I would like your support in presenting and continuing this highlights in radiology. Read it and focus on it, especially in the pre-exam periods, to refresh your memory about the different appearances of different kinds of tumors. And I will meet you again next week at Friday 5 p.m. with another episode of Highlights in Radiology. This was Dr. Ahmed D. Abdulwahab, and this was Highlights in Radiology. Bye.